Block simulation 15. Halfway through the set. Same process. Read the command first. Scan the clues. Build fast, lock, and move. 20 questions, 30 minutes. Clock starts now. What is the underlying mechanism of anemia? A 3-year-old child living in an old, poorly maintained house presents with irritability, abdominal pain, constipation, and developmental regression. Labs: microcytic anemia. Peripheral smear shows basophilic stippling of red cells. A blue line is noted along the gums. Read the command. Mechanism of the anemia: old house, abdominal pain, developmental regression, basophilic stippling, gum line. Lead poisoning impairing heme synthesis. Lead poisoning, classically from old lead-based paint in young children, impairs hemosynthesis. Lead inhibits two key enzymes of the heme pathway, ALA dehydrata and ferrochelatase, the enzyme that inserts iron into protoporphyrin in the final step. Blocking these causes a microcytic anemia, and the buildup of protoporphyrin and disrupted RNA degradation produces the characteristic basophilic stippling on the smear. Lead also causes the neurologic features, irritability, developmental regression, and cognitive impairment, plus abdominal pain and the lead line on the gums. The correct answer is B. The classic findings to lock in: lead poisoning causes a microcytic anemia with basophilic stippling, abdominal colic, the gingival lead line, and neurologic ecchymative effects, especially in children with pica. Ferrochelatase inhibition also raises free erythrocyte protoporphyrin. Treatment chelates the lead, succimer TDMSA or EDTA, and dimercaprol for severe poisoning. Basophilic stippling with the heme enzyme block is the lead mechanism. Which muscle type is this? A physiologist compares excitation-contraction coupling in different muscle types. In one type, the action potential triggers a small calcium influx that opens ryanodine receptors to release a large amount of calcium from the sarcoplasmic reticulum, calcium-induced calcium release, and contraction depends on extracellular calcium. Read the command, which muscle type? Calcium-induced calcium release dependent on extracellular calcium, cardiac muscle. This describes cardiac muscle. In cardiac myocytes, the action potential opens L-type calcium channels, allowing a small amount of extracellular calcium to enter during the plateau phase. That calcium triggers the ryanodine receptors on the sarcoplasmic reticulum to release a much larger store of calcium. Calcium-induced. Calcium release. This release calcium binds troponin C to enable contraction. Critically, because the trigger comes from outside the cell, cardiac contraction depends on extracellular calcium, which is why it is sensitive to calcium channel blockers and serum calcium. The correct answer is C. Contrast the muscle types. Skeletal muscle does not require extracellular calcium. Its action potential directly couples the voltage sensor, the HP receptor, mechanically to the ryanodine receptor, releasing SR calcium without needing calcium to enter the cell. Cardiac muscle requires the extracellular calcium trigger for CICR. Smooth muscle uses calcium binding to the calmodulin and myosin light chain kinase. The extracellular calcium-dependent CICR via ryanodine receptors is cardiac muscle. A deficiency of which vitamin explains these findings, and what is its role in vision? A 4-year-old child in a developing country with chronic malnutrition presents with difficulty seeing in dim light, night blindness, dry conjunctivae, and gray plaques on the conjunctivae without spots. He has had frequent infections. Read the command, which vitamin and its role in vision. Night blindness, dry conjunctiva, beetle spots, infections, vitamin A deficiency, retinol and rhodopsin. Vitamin A, retinol, is essential for vision, epithelial integrity, and immune function. In the eye, vitamin A is converted to retinol, which combines with the protein opsin to form rhodopsin, the visual pigment in the rod photoreceptors responsible for vision in dim light. Deficiency impairs rhodopsin regeneration, causing night blindness as the earliest sign. Vitamin A also maintains epithelial surfaces, so deficiency causes dry eyes. Xerophthalmia with betoid spots, corneal damage, keratomalacia, dry skin, and increased susceptibility to infections from impaired epithelial and immune defenses. The correct answer is B. Vitamin A deficiency is a leading cause of preventable childhood blindness worldwide, and supplementation reduces infectious mortality. Also know vitamin A toxicity acutely, headache and raised intracranial pressure, pseudotumor cerebri, chronically, dry skin, hepatotoxicity, and bone changes, and it is highly teratogenic, isotretinoin. The retinal role in rhodopsin explaining the night blindness and the epithelial role explaining the xerophthalmia point to vitamin A. Why are vibration and proprioception spared? A 68-year-old man with severe atherosclerosis suffers an occlusion of the artery supplying the anterior two-thirds of the spinal cord at the thoracic level. On exam below the lesion, bilateral flaccid then spastic paralysis and bilateral loss of pain and temperature, but preserved vibration and proprioception. Read the command. Why vibration and proprioception are spared? Anterior spinal artery occlusion with motor and pain temp loss, but preserved dorsal column function. In anterior spinal artery syndrome, the artery supplying the anterior two-thirds of the spinal cord is occluded. This infarcts the structures in the anterior and lateral cord, the sorticale spinal tracts, causing bilateral paralysis, flaccid acutely, spastic later, and the spinothalamic tracts, causing bilateral loss of pain and temperature below the lesion. The dorsal columns, which carry vibration and proprioception, sit in the posterior third of the cord and are supplied by the separate posterior spinal arteries, so they are spared. That is why vibration and proprioception remain intact. The correct answer is A. The vascular anatomy explains the deficit pattern. The single anterior spinal artery feeds the anterior two-thirds corticospinal and spinothalamic tracts, while the pair posterior spinal arteries feed the dorsal columns. So an anterior spinal artery infarct knocks out motor and pain temperature bilaterally but preserves the posteriorly supplied vibration and proprioception. The watershed thoracic region is especially vulnerable as after aortic surgery. The separate posterior arterial supply to the dorsal columns is the reason they are spared. What is the diagnosis and the mechanism of the hyperpigmentation? A 42-year-old woman presents with months of fatigue, weight loss, salt craving, dizziness on standing, and hyperpigmentation of skin creases and the buccal mucosa. Labs: sodium 128, potassium 5.6, glucose low. Morning cortisol is low and fails to rise after ACTH stimulation. ACTH is elevated. Read the command. Diagnosis and mechanism of hyperpigmentation. Fatigue, salt craving, hyperpigmentation, hyponatremia, hyperkalemia, low cortisol not responding to ACTH, high ACTH, primary adrenal insufficiency, Addison, ACTH, NBME-style, driven pigmentation. This is primary adrenal insufficiency. Addison disease, failure of the adrenal cortex itself. Loss of cortisol causes fatigue, weight loss, hypoglycemia, and hypotension. Loss of aldosterone causes salt wasting with hyponatremia, hyperkalemia, and volume depletion. Because the adrenal gland is failing, cortisol stays low even after ACTH stimulation, and the pituitary ramps up ACTH, so ACTH is hitches. The hyperpigmentation results from the high ACTH. ACTH is cleaved from the same precursor, POMC, as melanocyte-stimulating hormone, MSH, so excess ACTH stimulates melanocytes, darkening skin creases, scars, and the buccal mucosa. The correct answer is E. The hyperpigmentation is the key clue that distinguishes primary, Addison, high ACTH from secondary, adrenal insufficiency, pituitary failure, low ACTH, so no hyperpigmentation, and aldosterone is preserved since it is mainly renin-driven, so no hyperkalemia. So no hyperkalemia. High ACTH with hyperpigmentation plus the hyponatremia and hyperkalemia of aldosterone loss. points to hyponatremia of aldosterone loss, points to primary adrenal insufficiency. Treat with glucocorticoid and mineralocorticoid replacement. Which set of stimulators correctly drives parietal cell acid secretion? A physiologist studies the gastric parietal cell, which secretes hydrochloric acid via the H plus K plus ATPase proton pump on its apical membrane. 3 signals stimulate acid secretion. Read the command. Which set stimulates parietal cell acid? Gastrin, histamine, and acetylcholine stimulate the parietal cell. The parietal cell secretes hydrochloric acid through the H plus K plus ATPase, the proton pump, on its apical surface, and 3 stimulators drive it. Gastrin from antral G cells acts on the CCKB receptor. Histamine from enterochromaffin like ECL cells acts on the H2 receptor, and this is the most important because gastrin and acetylcholine largely work by triggering histamine release, which then potentiates acid secretion. Acetylcholine from vagal stimulation acts on the M3 muscarinic receptor. Together, these raise intracellular signals that activate the proton pump. The correct answer is A. This trio explains the pharmacology of acid suppression. Histamine's central role is why H2 blockers ranitidine, famotidine reduce acid. Blocking the final common pathway, the proton pump itself with PPIs, omeprazole is the most potent. Somatostatin and prostaglandins inhibit acid secretion, which is why NSAI aids, by blocking protective prostaglandins, promote ulcers. The gastrin, histamine, and acetylcholine triad stimulating the parietal cell is the answer. What is the mechanism of this drug class? A 55-year-old man with GERD and a duodenal ulcer is treated with omeprazole, which provides potent and long-lasting acid suppression. Read the command. Mechanism of omeprazole. Proton pump inhibitor. Irreversible inhibition of the H plus K plus ATPase. Omeprazole is a proton pump inhibitor. It irreversibly inhibits the H plus K plus ATPase, the proton pump, on the apical membrane of the gastric parietal cell. This pump is the final common step in acid secretion, the point at which hydrogen ions are actually pumped into the stomach lumen, so blocking it suppresses acid no matter which upstream stimulator, gastrin, histamine, or acetylcholine is active. PPIs are prodrugs activated in the acidic environment of the parietal cell, and because the inhibition is IR reversible, acid suppression is potent and lasts until new pumps are synthesized, explaining the long duration. The correct answer is B. Because PPIs block the final step, they are more effective than H2 blockers, which only block one of the 3 upstream stimulators, histamine. PPIs are used for GERD, peptic ulcers, H. pylori eradication regimens, and Zollinger. Ellison syndrome, long-term concerns include reduced calcium and B12 absorption, increased C. difficile risk, and hypomagnesemia. The irreversible proton pump inhibition is the mechanism of omeprazole. What is the most likely diagnosis? A 65-year-old man presents with fatigue, early satiety, and massive splenomegaly. CBC, anemia, variable, fibrosis, and platelet counts. Peripheral smear shows teardrop-shaped red cells, dacrocytes, and a leukoerythroblastic picture with nucleated red cells and immature myeloid forms. Bone marrow aspiration yields a dry tap. Biopsy shows extensive marrow fibrosis. CBC and dry tap. Biopsy shows extensive marrow fibrosis. JAT2 mutation is positive. Read the command, most likely diagnosis. Massive splenomegaly, teardrop cells, leukoerythroblastic smear, dry tap with marrow fibrosis, JAK2, primary myelofibrosis. Primary myelofibrosis is a myeloproliferative neoplasm in which the bone marrow is progressively replaced by fibrosis, driven by cytokines from conal proliferation, often with a JAK2 mutation. As the marrow fibrosis, hematopoiesis shifts to extramedullary sites, chiefly the spleen and liver, causing the massive splenomegaly. The peripheral smear is characteristic. Tear, rod-shaped red cells, dacrocytes, squeezed as they are forced out of the fibrotic marrow, along with a leukoerythroblastic picture of nucleated red cells in immature myeloid forms. Marrow aspiration fails, a dry tap, because of the fibrosis, requiring biopsy. The correct answer is B. The teardrop cells plus a leukoerythroblastic smear plus a fibrotic dry tap marrow with massive splenomegaly is the classic combination. JK2 mutations link it to the other myeloproliferative neoplasms, polycythemia vera, essential thrombocythemia. Both myelofibrosis and hairy cell leukemia give a dry tap, but the teardrop cells and marrow fibrosis distinguish myelofibrosis. The fibrotic marrow with teardrop cells defines primary myelofibrosis. What is the mechanism of the toxin? An unvaccinated 6-year-old immigrant presents with sore throat, low-grade fever, and a thick gray pseudomembrane coating the tonsils and pharynx that bleeds when scraped. He has bull neck lymphadenopathy. Days later, he develops myocarditis and a soft palate paralysis. Culture on tellurite Loeffler medium grows gram-positive rods with metachromatic granules. Read the command. Mechanism of the toxin. Unvaccinated child, gray pseudomembrane, bull neck, myocarditis, gram-positive rods with metachromatic granules, diphtheria, exotoxin. ADP ribosylating EF2. This is diphtheria caused by Corynebacterium diphtheria, a gram-positive rod that shows metachromatic granules and grows on tellurite and Loeffler media. Its diphtheria, exotoxin, works by ADP ribosylating elongation factor 2 EF2, inactivating it and halting host cell protein synthesis. This kills cells, producing a thick gray pseudomembrane in the pharynx, a layer of dead cells, fibrin, and bacteria that bleeds when scraped, the bull neck lymphadenopathy, and the systemic effects. Myocarditis and neuropathies like soft palate paralysis as the toxin spreads. The correct answer is E. This is the same molecular mechanism as Pseudomonas exotoxin A, both ADP ribosylate EF2. The toxin gene is carried by a lysogenic bacteriophage. The pseudomembrane, bull neck, and toxin-mediated myocarditis and neuropathy are the hallmarks. Treatment is antitoxin plus antibiotics, and prevention is the toxoid vaccine, the D in DTaP. The EF2 ADP ribosylation, halting protein synthesis, is the toxin mechanism. What is the correct sequence linking glucose to insulin secretion? A physiologist studies insulin secretion from a pancreatic beta cell. Glucose enters the cell, is metabolized to raise the ATP-ADP ratio, and this triggers a cascade ending in insulin release. Read the command, sequence linking glucose to insulin. Glucose, ATP, K ATP channels, K ATP channels, calcium influx, I insulin release. The beta cell couples glucose sensing to insulin released through a precise sequence. Glucose enters via GLU2 and is metabolized, raising the ATP-to-ADP ratio. The increased ATP closes. The ATP-sensitive potassium channels, K ATP channels. With potassium no longer leaving, the membrane depolarizes. Depolarization opens voltage-gated calcium channels, and calcium floods in. The rise in intracellular calcium triggers exocytosis of insulin-containing granules. So, glucose, then ATP up, then K ATP channels closed, then depolarization, then calcium influx, then insulin release. The correct answer is C. This pathway is the basis of sulfonylurea action. Drugs like glipizide close the same K ATP channel pharmacologically, depolarizing the beta cell and stimulating insulin release independent of glucose, which is why they can cause hypoglycemia. The K ATP channel is the central switch linking metabolic state to insulin secretion. The glucose, ATP, potassium, calcium cascade ending in exocytosis is the correct sequence. What is the most likely diagnosis? A 50-year-old man presents with edema, frothy urine, and weight gain. Labs, heavy proteinuria, IgG day, hypoalbuminemia, hyperlipidemia, nephrotic syndrome. Renal biopsy shows diffuse thickening of the glomerular basement membrane with spike and dome, appearance on silver stain and granular subepithelial IgG deposits. Anti-PLA2R antibodies are subepithelial IgG deposits. Anti-PLA2R antibodiemia. Read the command, most likely diagnosis. Adult nephrotic syndrome, spike and dome, subepithelial IgG, anti-PLA2R. Membranous nephropathy. Membranous nephropathy is a leading cause of primary nephrotic syndrome in adults. The pathology is diagnostic. Immune complexes deposit in the subepithelial space along the glomerular basement membrane, and the basement membrane reacts by laying down new material between the deposits, creating the spike and dome appearance on silver stain. Immunofluorescence shows granular subepithelial IgG and C3. The primary form is autoimmune, driven by antibodies against the podocyte antigen PLA2R, the phospholipase A2 receptor, which are positive here and are quite specific. The correct answer is E. Membranous nephropathy can be primary, anti-PLA2R, or secondary to infections, hepatitis B, drugs, NSAIDs, gold, SLE class, B lupus nephritis, or solid tumors, so a new diagnosis prompts a workup. It also carries a high risk of renal vein thrombosis from the hypercoagulable nephrotic state. The subepithelial spike and dome deposits with anti-PLA2R in an adult with nephrotic syndrome point to membranous nephropathy. What is this stroke syndrome, and which vessels are typically involved? A 70-year-old man with long-standing hypertension and diabetes suddenly develops weakness of the right face, arm, and leg, all to a similar degree, without any sensory loss, visual field defect, aphasia, or neglect. CT later shows a small infarct in the posterior limb of the internal capsule. Read the command, stroke syndrome and vessels. Pure motor hemiparesis, face, arm, leg equal without cortical signs, internal capsule infarct. Lacunar stroke of the lenticulostriate arteries. This is a lacunar infarct producing pure motor hemiparesis. Lacunar strokes are small infarcts deep in the brain, the internal capsule, basal ganglia, thalamus, and pons, caused by occlusion of the small penetrating arteries, especially the lenticulostriate branches of the middle cerebral artery. Chronic hypertension and diabetes damage these tiny vessels. Lipohyalinosis, the classic risk factors. Lacunae in the posterior limb of the internal capsule, where the cortical spinal fibers are tightly packed, causes weakness of the contralateral face, arm, and leg, equally with no cortical signs, no aphasia, neglect, visual field cut, or sensory loss, because the cortex is untouched. The correct answer is D. The absence of cortical signs is the key distinguishing feature from a large cortical MCA stroke, which will cause aphasia, neglect, or a gaze preference. The lacunar syndromes include pure motor, internal capsule, as here, pure sensory thalamus, ataxic hemiparesis, and dysarthria, clumsy hand. Hypertension and diabetes damaging the lenticulostriate penetrators, causing pure motor hemiparesis, is the lacunar stroke. What is this analytic principle called, and why is it used? In a randomized trial of a new drug, many patients in the treatment group stop taking the drug or switch to placebo, and some placebo patients start taking the active drug. To preserve the benefits of randomization, the analysis groups every patient according to the treatment they were originally assigned, regardless of what they actually received. Read the command, which principle and why. Analyzing patients by original assignment regardless of adherence, intention to treat, preserving randomization. This is intention to treat analysis. In an ITT analysis, every patient is analyzed in the group to which they were originally randomized, no matter what treatment they actually received, whether they dropped out, switched, or were non-adherent. The reason is that it preserves the benefits of randomization, the random assignment that balances confounders between groups. The moment you start excluding or reassigning patients based on what they actually did, you reintroduce selection bias, because adherence itself is often related to prognosis. ITT also gives a more conservative, real-world estimate of effectiveness. The correct answer is A. The contrast is PER, protocol analysis, which includes only patients who adhere to the protocol. This measures the drug's efficacy under ideal conditions, but breaks randomization and can bias results because adherent patients differ systematically from non-adherent ones. ITT is the gold standard for the primary analysis of a randomized trial. Analyzing by original assignment to preserve randomization is intention to treat. A deficiency of which enzyme is responsible, and why does it cause hemolysis? A neonate develops a hemolytic anemia. The red cells lack mitochondria and depend entirely on glycolysis for ATP. Enzyme testing shows deficient activity of the enzyme that catalyzes the final ATP generating step of glycolysis furophate to pyruvate. 2-pyruvate. Read the command, which enzyme and why hemolysis. RBC glycolysis, deficient peptidopyruvate step, high 2003 BPG, hemolytic anemia, pyruvate kinase deficiency. Pyruvate kinase catalyzes the final step of glycolysis, converting phosphoenolpyruvate to pyruvate and generating ATP. Mature red blood cells have NO mitochondria, so glycolysis is their only source of ATP. When pyruvate kinase is deficient, the red cell cannot make enough ATP. The ATP is needed to power the membrane ion pumps, the NOK-A ATPase, that maintains cell shape and hydration. So without it, the cells become rigid and dehydrated, lose their deformability, and are trapped and destroyed in the spleen, causing a chronic hemolytic anemia. This is the second most common enzymatic cause of hereditary hemolytic anemia, after G6PD deficiency. The correct answer is D. The elevated 2003 BPG is a clue. The block is at the END of glycolysis, so upstream intermediates including 2003 BPG accumulate. The high 2003 BPG actually redshifts the oxygen curve, improving tissue oxygen delivery and partly offsetting the anemia symptoms. Pyruvate kinase deficiency is autosomal recessive. The loss of ATP making red cells rigid and prone to splenic destruction is why it causes hemolysis. What is the diagnosis? And a key complication to monitor. A 25-year-old woman presents with vaginal bleeding and severe nausea in early pregnancy. Her uterus is larger than expected for dates, and beta-HCG is markedly elevated, far higher than a normal pregnancy. Ultrasound shows a snowstorm or cluster of grapes appearance with no fetus. Karyotype of the tissue is 46XX, entirely paternal in origin. Read the command, diagnosis, and key complication. Markedly high beta-HCG, snowstorm grape-like uterus with no fetus, 46XX, all paternal, complete high density-form mole, risk of choriocarcinoma. This is a complete high density-form mole, a gestational trophoblastic disease. It results from abnormal fertilization, classically when an empty egg, no maternal DNA, is fertilized, producing a 46XX karyotype that is entirely paternal in origin, with no viable fetus. The chorionic villi swell into grape-like hydropic vesicles, producing the cluster of grapes, gross appearance, and the snowstorm pattern on ultrasound. The proliferating trophoblast secretes huge amounts of beta-HCG, far above a normal pregnancy, explaining the enlarged uterus, hyperemesis, and sometimes early preeclampsia or hyperthyroidism. The correct answer is D. The key complication to monitor is malignant transformation. A complete mole can progress to an invasive mole or choriocarcinoma, an aggressive trophoblastic malignancy that spreads hematogenously, classically to the lungs. After evacuation of the mole, beta-HCG is trended serially to ensure it falls to zero. A rising or plateauing HCG signals persistent trophoblastic disease. The 46XX all-paternal mole with markedly elevated HCG and its choriocarcinoma risk is the answer. What happens to the venous return curve and the operating point? A physiologist plots the cardiac output curve and the venous return curve on the same axis. They intersect at the operating point. A patient is given a blood transfusion that increases blood volume. Read the command, effect of increased volume on venous return curve and operating point. Transfusion raises mean systemic filling pressure, shifts VR curve right, raises cardiac output. Cardiac output is determined by the intersection of the cardiac output curve, the heart's pumping ability, and the venous return curve, how much blood returns to the heart. The venous return curve depends on the mean systemic filling pressure, the pressure in the vascular system when the heart is stopped, which reflects blood volume and venous tone. A transfusion increases blood volume, which raises the mean systemic filling pressure. This shifts the venous return curve to the right edge. It crosses the x-axis at a higher pressure, and the new intersection with the cardiac output curve occurs at a higher cardiac output and higher right atrial pressure. The correct answer is E. This Guyton framework explains many states. Increasing blood volume transfusion, or venous tone sympathetic activation, raises the mean systemic filling pressure and shifts venous return rightward, raising cardiac output. Hemorrhage does the opposite. Changes in contractility shift the cardiac output curve instead. A transfusion raising the mean systemic filling pressure, shifting venous return rightward, and increasing the equilibrium cardiac output is the answer. What is the most likely diagnosis? A 30-year-old man presents with sharp pleuritic chest pain that is worsy when lying flat and relieved by sitting forward, a few days after a viral upper respiratory illness. Auscultation reveals a scratchy 3-component friction rub. ECG shows diffuse ST segment elevation and PR segment depression in multiple leads. Read the command, most likely diagnosis. Positional pleuritic chest pain relieved by sitting forward, friction rub, diffuse ST elevation with PR depression, post-viral acute pericarditis. This is acute pericarditis, inflammation of the pericardium, most often viral or idiopathic, frequently after an upper respiratory infection. The pain is sharp and pleuritic, classically worsy lying flat and relieved by sitting up and leaning forward, which reduces pressure on the inflamed pericardium. The scratchy, 3-component friction rub is from the inflamed pericardial layers rubbing together. The ECG is distinctive, diffuse C-segment elevation across multiple leads not confined to a single coronary territory with PR segment depression, features that separate it from a myocardial infarction. The correct answer is A. The key contrast with myocardial infarction is the ECG pattern. Pericarditis causes diffuse ST elevation with PR depression, while an MI causes ST elevation in a localized coronary distribution with reciprocal changes. The positional pain, better sitting forward, and friction rub are also specific. Complications include pericardial effusion and tamponade. Treatment is NSAIDs plus colchicine. Positional pleuritic pain with a friction rub and diffuse ST elevation is acute pericarditis. What is the mechanism of this drug's characteristic toxicity and a protective agent? A 14-year-old boy with Hodgkin lymphoma is treated with a chemotherapy regimen including doxorubicin and anthracycline. His cumulative dose is tracked, and serial echocardiograms monitor his ejection fraction, which begins to decline. Read the command, mechanism of doxorubicin toxicity and protective agent. Anthracycline, declining ejection fraction, dose tracked, dilated cardiomyopathy from free radicals, protected by dexamethasone. Doxorubicin and the other anthracyclines have a signature dose-dependent cardiotoxicity. The mechanism is generation of free radicals, reactive oxygen species, within cardiac myocytes which lack robust antioxidant defenses. The oxidative damage injures the myocardium and, with cumulative dosing, leads to a dilated cardiomyopathy with declining ejection fraction and heart failure. This is why the cumulative lifetime dose is tracked and ejection fraction is monitored with serial echocardiograms. The protective agent is dexrazoxanine, an iron-chelating antioxidant that reduces free radical formation. The correct answer is C. Match each chemotherapy agent to its specific toxicity and protective measure. Anthracyclines, doxorubicin, cardiotoxicity, protected by dexrazoxane protection, signature toxicity, carcicity, signature toxicity, cancer, hemorrhagic cystitis, prevented by mesna, vincristine, can, peripheral neuropathy, can spatini, can, toxicity, and ototoxicity with amifostine. Which organism is responsible? And what is its vector? A 10-year-old boy from North Carolina develops high fever, severe headache, and myalgias after a summer camping trip. A few days later, a maculopapular rash appears on his wrists and ankles, including the palms and soles, and spreads centrally toward the trunk. He recalls a tick bite. Read the command, organism and vector. Southeast U.S. Fever, headache, rash starting on wrists, ankles, including palms, say soles, spreading centrally, tick bite, Rocky Mountain spotted fever, rickettsia via dermacentor. This is Rocky Mountain spotted fever caused by rickettsia, an obligate intracellular bacterium, transmitted by the dermacentor tick, the dog or wood tick. Despite the name, it is most common in the southeastern and south central United States. The classic presentation is high fever, severe headache, and myalgias, followed in a few days by a maculopapular, then petechial rash that characteristically begins peripherally on the wrists and ankles, including the palms and soles, and spreads centripetally toward the trunk. Rickettsia invades vascular endothelium, causing a vasculitis that produces the rash and can lead to shock. The correct answer is C. The peripheral to central rash, including the palms and soles, is the key clue. The short differential for a rash on the palms and soles is Rocky Mountain spotted fever, secondary syphilis, and Coxsackie virus. Treatment is doxycycline, given empirically on clinical suspicion even in children, because delay is dangerous. The centripetal palm and sole rash after a tick bite from a dermacentor vector is RMSF from Rickettsia. A defect in which kidney process underlies this disorder. A 6-year-old boy presents with poor coordination and an unsteady gait, cerebellar ataxia, and dilated blood vessels, telangiectasias on the conjunctiva and skin. He has recurrent sinopulmonary infections and low IgA. He is noted to have an increased sensitivity to ionizing radiation and a heightened risk of lymphoma. Lab shows elevated alpha-fetoprotein. Read the command, which Cheney process? Cerebellar ataxia, telangiectasias, recurrent infections with low IgA, radiation sensitivity, lymphoma risk, ataxia, telangiectasia, ATM gene, DNA repair defect. Ataxia telangiectasia is an autosomal recessive disorder caused by a defect in the ATM gene. Ataxia telangiectasia mutated. ATM encodes a kinase that senses and coordinates the repair of DNA, dual, strand breaks, and activates cell cycle checkpoints. When it is defective, cells cannot properly repair DNA damage, which explains the heightened sensitivity to ionizing radiation and the markedly increased risk of malignancy, especially LY lymphomas and leukemias. The classic clinical triad is cerebellar ataxia progressive from Purkinje cell degeneration, oculocutaneous telangy, ectasias, and eye immunodeficiency, particularly low IgA, causing recurrent sinopulmonary insufficiency, particularly low IgA, causing recurrent sinopulmonary infections. Alpha-fetoprotein is often elevated. The correct answer is D. The triad, ataxia, telangiectasia, and immunodeficiency, low IgA, plus radiation sensitivity, cancer predisposition, and elevated AFP defines the condition, and the failure of ATM-mediated DNA double-strand break repair is the unifying mechanism. This is one of the DNA repair defect syndromes, alongside xeroderma pigmentosum, nucleotide excision repair, and Fanconi anemia. The ATM gene defect in DNA double-strand break repair underlies ataxia, telangiectasia. Block 15 is done. The halfway mark of the full set. Let's review the 5 biggest traps from this block. Trap 1. Lead poisoning causes a microcytic anemia with basophilic stippling by inhibiting ferrochelatase and ALA dehydratase in hemosynthesis, plus neurologic and abdominal symptoms, classically in children with pica. Trap 2. Hyperpigmentation distinguishes primary adrenal insufficiency, where high ACTH drives melanocytes and aldosterone loss causes hyperkalemia, from secondary, where ACTH is low with no pigmentation. Trap 3. Membranous nephropathy is a leading adult nephrotic syndrome with subepithelial IgG deposits, a spike and dome basement membrane, and anti-PLA2R antibodies, and a high risk of renal vein thrombosis. Trap 4. Olagunar, infarct in the internal capsule, causes pure motor hemiparesis with no cortical signs, no aphasia or neglect, from small lenticular straight vessel disease driven by hypertension and diabetes. Trap 5. Intention to treat analyzes patients by their original randomized group regardless of adherence, preserving randomization and giving a real-world estimate. Her protocol analysis only includes adherent patients and can bias results. Halfway home. 15 blocks, 300 questions. Train process, not memorization. StepLogic, learn how to think, not memorize.